Hi, my name is Dr. Raj Gupta, and I'm a professor of radiology at Duke University Medical Center. I'm happy to be here with you today to talk about the use of EOVIST. EOVIST is indicated for intravenous use in magnetic resonance imaging of the liver to detect and characterize lesions in patients with known or suspected focal liver disease. Please note that I am being compensated by Bayer to support this presentation. Today, I'm going to show you examples of cases of how I've used EOVIST to image our patients. EOVIST is the first and only FDA-approved hepatobiliary-specific contrast agent for liver MRI. It combines dynamic and functional imaging information for comprehensive liver imaging, which can be done in under 30 minutes. One appealing aspect of the agent for me is that EOVIST dose is delivered in half the volume of an extracellular gadolinium-based contrast, which are typically dosed at 0.2 milliliters per kilogram of body weight, and EOVIST also contains approximately a quarter of the dose of gadolinium. I've used this agent in my practice for over 15 years and hope that the cases that I'm going to show you today will help you see some of the reasons why I've chosen to implement it in my practice. I'm currently using EOVIST in the differentiation of focal nodular hyperplasia from adenomas, the evaluation and follow-up of patients with both hypovascular and hypervascular metastatic disease, and also in the pretreatment and post-treatment assessment of patients with metastatic liver disease.
It is important to know that intrathecal administration of GBCAs can cause serious reactions, including death. EOVIST is not approved for intrathecal use. Additionally, GBCAs increase the risk for NSF among patients with impaired elimination of the drugs. Avoid use in these patients. The risk of NSF appears highest among patients with chronic severe kidney disease or acute kidney injury. Screen patients for conditions that may reduce renal function. For patients at highest risk, do not exceed the recommended dose.
Before we start to review some cases, I want to ensure you're clear on how EOVIST is dosed. Unlike other gadolinium-based contrast agents, EOVIST is dosed at 0.025 millimoles of gadolinium per kilogram, and the recommended dose of EOVIST is 0.1 milliliters per kilogram of body weight. So looking at the following example, if we have a patient who weighs 100 kilograms, their dose of EOVIST would be 10 milliliters. In comparison, for a gadolinium-based contrast agent dosed at 0.1 millimoles per kilogram of body weight or 0.2 milliliters per kilogram of body weight, that patient who is 100 kilograms would receive 20 milliliters of extracellular gadolinium-based contrast agents. So in this particular case, EOVIST has half the volume and a quarter of the gadolinium as compared to the gadolinium-based contrast agent seen in the second box. It's important to have a method to easily calculate appropriate dosage. If your department uses multiple contrast agents, it might benefit to your team to have a clearly defined dosing chart. So for this first case, we're going to talk about the use of EOVIST in the differentiation of focal nodular hyperplasia from adenomas. We're actually going to start this case by taking a look at a liver ultrasound that was performed on a 40-year-old female who came in for evaluation of abdominal pain. We did not find etiology for her abdominal pain on this study, but what we did find, seen in the right hepatic lobe here, is an incidental liver lesion. So at this point here, one of the big conversation pieces is to decide what should we do next to evaluate and characterize this focal liver lesion. And given this patient's age and the differential diagnosis of what we thought this might be, which is potentially focal nodular hyperplasia or adenoma in this patient who did not have a history of metastatic disease, we chose to use an MRI using EOVIST. So this is the MRI of the liver that was performed with EOVIST to further evaluate and characterize this lesion that we found on the liver ultrasound. So as we work our way through a comprehensive liver MRI, I'm going to share with you some of the ways that I take a look at a case and try to assess what the underlying etiology of a lesion might be. So first, we'd like to start with a T2 weighted image. And on this T2 weighted image, what we see as we go through the liver is that in the area that we saw the abnormality on the ultrasound, we see what looks like a pretty stealthy lesion adjacent to the gallbladder. And that is located here. Once we have that information from the T2, that helps me to determine what the underlying signal on T2 weighted imaging of this lesion is. And the stealthy appearance really does help me guide me in a direction of what I think this lesion might be. The next important thing is taking a look at a pre-contrast image to see what the pre-contrast signal of this lesion might be as well. And so as we take a look through this image set, we can see that in the same location here, we've got a lesion that is pretty iso-intense to the background liver. We take that and now we move over to our arterial phase images. And our arterial phase images are going to give us important information on whether or not this lesion is hypervascular against the adjacent background liver or hypovascular. And as we move through the liver MR here on the arterial phase, you will note that this lesion is markedly hypervascular to the background liver. And so the combination of a stealthy lesion on T2 weighted images and a hypervascular lesion on the arterial phase images, especially with its lobulated contour, really has started driving me towards a diagnosis of focal nodular hyperplasia. However, for me to feel comfortable with that, I need to take a look at the remainder of the dynamic phase images to really help clinch that diagnosis. And so as we move over to the portal venous phase images, we can take a look and see that this lesion against the background of the liver kind of remains a little bit brighter than the background, but overall pretty similar to the background. And then the final stage of the evaluation for me here is a 15-minute delayed image in the hepatobiliary phase. And here in this 15-minute delayed image, you can see that the liver is characteristically bright. This is one of the important features of EOVIST imaging that we use to know that we are in a hepatobiliary phase. The second thing that we use to figure out that we're in a hepatobiliary phase is this characteristic excretion of the contrast into the biliary system, and this helps me feel comfortable that I've achieved an appropriate hepatobiliary phase. So now as I move towards the remainder of the image, I'm going to use the hepatobiliary phase images to characterize this lesion further and hopefully come to a diagnosis. And as we move down through, we can see that this lesion demonstrates the characteristic hyper intense signal against the background liver that characterizes focal nodular hyperplasia. And I'm just going to go ahead and zoom in a little bit on this image just to give you a sense about what that really looks like. And so as I take into account these various imaging features, I can feel really comfortable that the diagnosis in this case is focal nodular hyperplasia. And this is a very common use of EOVIST in clinical practice, the differentiation of those entities of FNH versus adenoma.
The combination of non-contrasted and EOVIST contrasted magnetic resonance, or MR, images has improved sensitivity for the detection and characterization of liver lesions compared to pre-contrasted MR images, demonstrated in tables 1 and 2 on next slide. The improved sensitivity in detection of lesions was predominantly related to the detection of additional lesions among patients with multiple lesions on the pre-contrast MR images. The false positive rates for detection of lesions were similar for non-contrasted MR images and EOVIST contrasted MR images, 32% versus 34% respectively. Liver lesion detection and characterization results were similar between computerized tomography, or CT, and the combination of pre-contrasted and EOVIST contrasted MR images. Table 2, shown here, demonstrates the proportion of correctly characterized lesions per each diagnostic procedure. EOVIST is contraindicated in patients with history of severe hypersensitivity reactions to EOVIST. Anaphylactic and other hypersensitivity reactions ranging from mild to severe have uncommonly occurred. Before EOVIST administration, assess all patients for any history of a reaction to contrast media, bronchial asthma, and allergic disorders. Gadolinium is retained for months or years in several organs. Linear GBCAs cause more retention than macrocyclic GBCAs. Consequences of gadolinium retention in the brain have not been established, but they have been established in the skin and other organs in patients with impaired renal function. Certain patients may be at higher risk. Consider the retention characteristics of the GBCA and minimize repetitive GBCA studies when possible.
Okay, so we've now talked about case 1, which was focal nodular hyperplasia versus adenoma. I'd like to move on now to case 2, which is a case of metastatic disease. It's important to realize that when we think about metastatic disease, the traditional teaching of metastatic disease in the liver is that liver lesions are either hypovascular or hypervascular relative to their background. And that is the teaching that has been used throughout as we try to differentiate tumor types. So there are certain types of tumor that are hypovascular to the background, thinking colon and lung and prostate. Then there are some tumor types that are hypervascular to the liver background, And for that, I'm thinking of things like renal cell carcinoma, neuroendocrine, etc. So, one important thing to realize is that all of those tumor types, while they may have differing appearances on the arterial phase and the portal venous phase, will actually look quite similar when you go to the delayed hepatobiliary phase of imaging, where they should all be hypointense relative to the background of the liver. And in this particular case, I'm going to show you some metastatic lesions in a patient with neuroendocrine tumor. So this patient had a history of neuroendocrine tumor, and is the protocol that I use for metastatic disease, we use EAVIST. And so I want to first start with the T2 weighted images to compare and contrast what we found in the previous case with that stealthy lesion with what we have in this case, which is a T2 intermediate signal lesion here and here. So this is in the posterior segment of the right hepatic lobe. This appearance is much more worrisome than our stealthy appearance. Our stealthy appearance led us to feel about focal nodular hyperplasia. This T2 gray appearance, or what some people call tumoral gray, is really worrisome for metastatic disease. So we take into account these T2 information as we move on to our dynamic phase evaluation. So as we start thinking about liver imaging this patient with neuroendocrine tumor, the first thing that we're going to do is take a look at our T2 weighted images. And in the prior case, I talked to you a little bit about the stealthy appearance of focal nodular hyperplasia. I want you to compare and contrast that appearance with the appearance of metastatic disease. This lesion has a T2 gray or a tumoral gray or an intermediate T2 signal, as does its lesion adjacent to it. These findings are much more suspicious for metastatic disease and really raise my level of concern when I take a look at this. However, T2 weighted images should always be taken into account relative to the dynamic images that we have as part of an EAVIST examination. And in this case here with neuroendocrine, we might expect that these lesions would be hypervascular. You can see quite subtly here that there is some hypervascularity, and you really need to change your windows to see that this thing demonstrates hypervascularity. But in order to fully characterize this lesion as we continue to move through our phases of imaging, I'm now going to bring up the portal venous phase images on this side. And as we work our way through, you can see that there are many more lesions throughout this liver. And these lesions all represent metastatic neuroendocrine tumor. But the place at which these lesions are perhaps most pronounced, and where I like to do my what I call apples to apples comparison in the longitudinal setting, is using the delayed hepatobiliary phase images to really get a sense for this. And so here's the delayed hepatobiliary phase obtained at 20 minutes, and you'll just notice the conspicuity change of these lesions against the brighter background. And just so you understand, what's going on here is that the agent is being uptaked by the liver. The liver is increasing in signal. These lesions are not uptaking the contrast agent, and therefore they are markedly hypointense relative to the background. The thing I like about this phase is I feel as though it is a reproducible way for me to measure lesions at the beginning and also throughout this patient's cancer journey, hopefully as these things get smaller in size. But just want to draw your attention to the fact that these hypervascular liver metastatic disease is really clearly hypointense on the delayed hepatobiliary phase images. And this phase is what I like to use when assessing them. Okay, and then we're going to move to our final case, and that's case 3, where we're going to talk about colorectal cancer, metastatic disease to the liver. So this patient is a young patient who was newly diagnosed with colorectal cancer, and they had metastatic disease in their liver. One of the treatment options that we have available for some of these patients is hepatic arterial infusion pumps. And hepatic arterial infusion pumps require a few different things. Obviously, a surgeon who's going to be putting those pumps in, and then a comprehensive evaluation of the liver that gives an understanding of the arterial supply to the liver, the arterial anatomy of the liver, as well as the volume and distribution of metastatic disease through the liver. And that needs to be done in the pre-operative setting as well as throughout the disease course of that patient. So in this next case, I'm going to show you a little bit about what we look for in the preoperative assessment of a patient for hepatic arterial infusion pumps. Okay, so as you all know, I like to take a look at T2 weighted images when I'm starting to take a look at a liver MRI, and this liver MRI is no exception. So when we take a look at the T2 weighted images on this particular case, what we can first get a sense for are lesions that look a lot like the neuroendocrine metastatic disease that we saw in the prior case, that what we call tumoral gray appearance, which is T2 intermediate signal. And unfortunately, this indicates that we have a large volume of metastatic disease for this patient. So as I mentioned, this patient was being considered for placement of a hepatic arterial infusion pump. And one of the things that is required as we do that thing is to provide our referring surgeon with information on the arterial vasculature. And that's really where our arterial phase images come into play here. Our arterial phase images here allow us to show the anatomy of the aorta and the celiac axis, as well as the branching pattern of the hepatic arterial supply going over to the left and to the right. This kind of information is critical, including the presence or absence of anatomic variants. And this information is what we put into the report so that the surgeon has the most information that they need as they plan for their pump placement. The next thing that we're going to do as part of a comprehensive evaluation of the liver is really quantifying and characterizing the liver lesions that are present inside this patient. And so here, what we have is we have portal venous phase images, and these portal venous phase images really help us understand, unfortunately, the breadth and number and distribution of the lesions inside their liver. Now, important thing to realize about EOVIST MRI, you can actually tell what phase you're on by taking a look at the vasculature and the liver relative to the lesions. So these are hypovascular liver mets, which means they are going to be hypointense to the liver on the portal venous phase of imaging. We can tell here that we're in the portal venous phase of imaging because the portal vein here is bright relative to the background liver. Now compare and contrast that appearance of the portal vein to the delayed hepatobiliary phase images, which occurs around 15 minutes. In this phase here, you can see that we also have hypointense lesions to the background of the liver, but the liver looks very different than it does on the portal venous phase images here. The way you can tell what phase you're in here is notice that the blood pool here, the portal vein is dark compared to the background liver. The liver parenchyma is quite bright, and that's because of the timing of the contrast agent. And as he talked about in the previous case, how we know we're in the hepatobiliary phase of imaging is the presence of bright signal inside the liver, as well as excreted contrast through the biliary system. And that's what we see here. It's really important when you're doing EOVIST examinations to understand what phases you're in, because that will help you with both lesion characterization and detection. So this is the test that I prefer to use when we are doing evaluation of treatment options in the setting of colorectal cancer, because it gives me a good longitudinal assessment of where the lesions are, how big they are, and what the impact of treatment is. And so this is an example of how we use EOVIST enhanced MRI in the setting of pretreatment for colorectal patients.
In patients with chronic renal impairment, acute kidney injury, sometimes requiring dialysis, has been observed with GBCAs. Do not exceed the recommended dose, as this may increase risk. Ensure catheter and venous patency before injecting EOVIST, as extravasation into tissues may result in local tissue reactions. Strictly avoid intramuscular administration. Serum iron determination using complexometric methods may result in falsely high or low values for up to 24 hours after the examination with EOVIST. End-stage renal failure or hepatic failure may impair EOVIST imaging performance. The most frequent adverse reactions associated with EOVIST in clinical studies were nausea, headache, feeling hot, dizziness, and back pain.
So as we conclude, I hope that this has been a helpful review of the use of EOVIST in clinical practice. As you can see, I've used the agent for many years, and I've tried to show you real examples from my clinical practice where I found that it's helped me. Specifically, we talked about the use of EOVIST in the detection and characterization of focal nodular hyperplasia versus adenomas, and also showed you its use in metastatic disease, both of the hypervascular subtype as well as the hypovascular subtype. I hope this has been helpful and hope all of you have a great day. Thanks.